Right, good morning everybody. Let me just get my slides to show started. There it is actually. Try and go through pregnancy in patients with disease. So I get the question, pediatric cardiology in India, becomes more established. We will be seeing more and more patients who are of an older age. Obviously, you have untreated congenital heart disease, which we still continue to see, unfortunately. But also there will be patients who've had surgery for congenital heart disease, who will come back to you at a quote-unquote marriageable age and want to know whether they can get pregnant, or they may come back to you already pregnant, wanting to know if everything will be okay. So, how do you make decisions, informed decisions on these patients? Can these patients get pregnant? Is it safe? What are the risks involved? And can you categorize these patients? Are some patients more prone to problems than others? So these are the various issues, hopefully, that we'll have some clarity on at the end of this talk. So firstly, if you look at the cardiovascular changes that happen during pregnancy, even in a person with normal, in a woman with a normal heart, you see on this graph, I can get my pointer to work. So you have the green and the blue lines are heart rate and cardiac output. So you see that by the end of the first trimester, so somewhere around the 14-16 week mark, the cardiac output and the heart rate, stroke volume, all of these have actually peaked. And then they actually stay at a plateau throughout pregnancy. So what we're trying to say here is that the woman cannot increase her cardiac output. So her cardiac output maxes or achieves maximum at about 16-week gestation. Following that, it stays steady. However, the plasma volume or the circulating volume in the woman increases. So it exponentially increases, particularly during the second trimester, and it sort of peaks between the 32 to 36 week window. So just prior to delivery is when the woman has maximum circulating volume. So if the cardiac output and the stroke volume are all steady, then where is all this plasma volume? All of this plasma volume is either it's in the extravascular space. So you see a lot of pregnant women are swollen up. So all the fluid is out there, or it's in the placenta. So there's a lot of extravascular fluid accumulation during the late stage of pregnancy. But if you look at actual cardiac output and stroke volume, that reaches a maximum at about 16 weeks gestation. Okay. So going back to the question of can women with heart disease get pregnant safely? The answer to that is yes, the majority of them can. So if you look at the contraindications to pregnancy, the absolute contraindications where you would tell somebody, look, it is not safe for you to get pregnant. It is probably better to avoid pregnancy and think about an alternative way of having a child, like adoption perhaps. So, and the important contraindications to pregnancy in women with congenital heart disease are: 1, pulmonary hypertension. There is about 50%, 40 to 50% mortality in people who have high pulmonary artery pressures. And by high, I don't mean systemic. Even if it's just 50% of systemic, then they are at risk of having mortality as a result of pregnancy. Also, there can be an aggravation in the pulmonary vascular disease. It can become more aggressive, more pronounced. So overall, pregnancy is not a good thing for a pulmonary hypertensive woman. Then, of course, systemic ventricular dysfunction. Any degree of systemic ventricular dysfunction does put the woman at risk. But if you have a ventricular ejection fraction less than 20%, you should not really be embarking on pregnancy. The difficulty is, particularly in our context, also in the West, that women are perhaps not counseled properly during their adolescent years. The transition between pediatric cardiac care and adult congenital care is a very tricky one, because throughout childhood the parents have been looking after the child, and when they hit adolescence, the child often comes with their parents. It becomes awkward to discuss some issues like contraception and pregnancy with a young girl with her dad in the room. So I think it is good practice, as things progress, as cardiology progresses in this country, and as all of you guys go out there to practice, that we should actually make it a point, particularly in sort of the older teenagers and perhaps the young adults, that we spend some alone time with them, going through these issues that perhaps they cannot talk about in front of people who are accompanying them. Ventricular dysfunction is a severe ventricular dysfunction is a big contraindication again to pregnancy. Severe left side obstructive lesions, again, patients can get into an immense amount of trouble if they've got severe mitral or aortic stenosis. And if the patient does desire to get pregnant, perhaps something needs to be done prior to conception, rather than allow them to get pregnant and get into trouble. And another important group is the group with Marfan's syndrome and a dilated aortic root. These patients are at an increased risk of aortic root rupture. If you have Marfan's even without a dilated aortic root, you have a 1% chance of aortic rupture, okay? Even without a dilated aortic root. But with a dilated aortic root, your chances of aortic rupture and therefore death and adverse outcomes are increased many-fold. So I think these patients have to be considered, particularly if they have a dilated aorta, a rapidly dilating aorta, if they have an adverse family history. These are all warning signs, and these patients should be counseled against getting pregnant, because it's not just the delivery side of things that's the problem. It's the estrogen during pregnancy that plays havoc with their aorta and actually worsens the aortic root dilatation. So these patients have to be counseled against pregnancy. Right. So if you look, I mean, we've talked so far about congenital heart disease. Now, this is some data from the UK, and it shows you the split up. Now, this is maternal mortality data. So all these women died during pregnancy. And it looks at only the cardiac causes of maternal mortality. So cardiac causes were amongst the top two. When they looked at all causes of maternal mortality, cardiac causes were right at the top. Okay. But if you look at the types of cardiac diseases, you see that the majority of diseases that cause mortality were acquired. Okay, so it could be cardiomyopathy, it could be pulmonary hypertension. Again, this I suppose could be either primary or secondary to a congenital heart disease. Then there is an entity called peripartum cardiomyopathy, which is quite distinct from the usual dilated cardiomyopathy. Then you have MI, aortic dissection. Anyway, a variety of causes, but the point to highlight is the overall, the group that we would normally consider congenital heart disease form a small proportion of this group. So acquired heart disease is as important, and in our context, rheumatic heart disease is an important player as well, because a lot of young people of that age do suffer from rheumatic valvular disease, and the particularly MS and AS can be nasty lesions to have during pregnancy. So, what is the maternal and fetal risk associated with congenital heart disease? So, if you look at there are small retrospective series that have been published, okay, and you look at various groups of patients with congenital heart disease. Also, they looked at their own Gooch population. Basically, the department has gone through its Gooch database and looked at how many women got pregnant, etc., etc. And there are a few. If you look in published literature, I could locate 2 or 3 papers like this. A few hundred women who had gotten pregnant, and amongst them, the data on obstetric outcomes, fetal outcomes, and cardiac outcomes have been reported. So if you notice that the risk of cesarean section in these women is about 20 to 30%, and some of them for cardiac causes, some of them for obstetric causes. Okay. Then the risk of maternal adverse events, which could be a worsening in heart failure, need for hospitalization, worsening arrhythmias. These are all reported variably between 15 and 20%. But remember, these are all small studies. Okay, they are looking selectively at a subgroup of patients who are registered with a congenital heart disease unit, and these come from North America. Okay, so in North America, you don't have universal health care. So a lot of patients who have congenital heart disease, they get health care when they're children, for free. But once they reach adult congenital age, they lose their free health care and they are not covered by insurance. So they're in a really trouble spot. So I think the data has to be taken with a pinch of salt. But you see that there is a significant risk of cesarean section, maternal and fetal adverse events. Okay. Now, recently, there was a study that has been published from the US. It's in press at the moment in the Annals of Thoracic Surgery. So it looks at the US national birth data. So over a period of 10 years, 40 million births, and 27,000 of these women had grown-up congenital heart disease. And what they found out was that maternal mortality was 18 times higher in the Gooch patients compared to women without Gooch. So this is a significant difference. So being pregnant with congenital heart disease does carry risk. Now that doesn't mean to say, but the percentage is still small, 0.09%. Okay, doesn't mean to say that women with congenital heart disease cannot get pregnant, because that would be false. But I think they just need careful evaluation and careful selection, good counseling, careful follow-up, and proper appropriate delivery arrangements. So all these factors can ensure that we improve the maternal and fetal outcomes in this subgroup of patients who are at a higher risk. So here you also see the complication rates. So cardiac complications were 2.3% in the Gooch patients versus 0.2% in the non-Gooch patients. And again, there's a slightly increased rate of need for induction, need for cesarean deliveries, and the incidence of premature deliveries. Okay, so yes, having Gooch and being pregnant does put the patient at an increased risk during pregnancy. However, this is not a contraindication for all women, for pregnancy. So, okay, when the patient comes to you for an antenatal clinic, they have to be, obviously, first, the ideal way to deal with the situation is actually to meet the woman prior to conception, okay, so that she can be given pre-conception advice, i.e. she can be advised about what is the right time for her to get pregnant, whether it is safe for her to get pregnant at all. She can receive some information about what is the risk to her versus what is the risk to the baby. What sort of obstetric care she needs during pregnancy, how often she needs to be seen, does she require a fetal echocardiogram during pregnancy, and also to decide the timing of the delivery, where the delivery should be carried out. Home deliveries are not ideal in this situation. So, these are all sort of issues to address. So they need to be in a hospital type setup, etc. And also, most importantly, a lot of patients will ask you quite rightly what the chances of recurrence are. What is the likelihood that the child that they carry will have the same heart problem or a similar heart problem. So, the maternal risk involves not just mortality but also morbidity. Of course, there is risk that a woman could die during pregnancy, but also it could leave her worse off. It could cause hospitalization. It can cause an increased risk of arrhythmias, new onset arrhythmias, and worsening of existing arrhythmias. It may require alterations in medications. For example, if a patient has a metal valve in, they may have to alter their anticoagulation therapy, and this puts them at risk of valve problems. So these are all the various risks that need to be explained to the patient so that they are making an informed choice to get pregnant. And also in the long term, after pregnancy, if there is a deterioration in, say, arrhythmia or ventricular function, this deterioration might persist. So they need to be warned that once pregnancy is over, they may not return to baseline state and their ventricular function and NYHA might have deteriorated slightly. So then you have fetal risk. So of course, due to a variety of reasons, there is a very high incidence of miscarriage, of fetal loss, and intrauterine death in these patients. Also, once the baby is born, babies can be born more, premature deliveries can happen, and also they are at increased risk of RDS and neonatal complications. So all of these various things have to be explained to the mother. Timing of pregnancy is important. Now, particularly in subgroups of patients who have a systemic right ventricle, say for example CTGA or atrial switch. Here the RV is a systemic ventricle, and we all know that the RV in a systemic position fails at some point, and this is often in the third decade. So if you have a woman with an atrial switch operation or a congenitally corrected transposition, and she wants to get pregnant, encourage her to get pregnant early, so that in her 20s, when her ventricle is doing much better, she gets the strain of pregnancy and delivery out of the way. So timing of pregnancy is important. Need for intervention prior to conception. So like I said, pre-conception, visit to the adult congenital specialist is ideal. Doesn't happen, but it's ideal. So if you determine that, say that patient has got severe AS or severe MS prior to conception, you can do an interventional procedure. You can balloon the mitral valve, you can balloon the aortic valve, something to reduce the gradient, something to allow the woman to complete the pregnancy safely. And then later on she can have a more definitive procedure like a valve replacement. So that needs to be assessed. Is there something that needs to be done prior to conception? Then once the woman has become pregnant, obviously you need to have a plan as to how you follow her up during pregnancy. So these ladies will need regular follow-up during pregnancy, and after the first visit, probably a couple of visits during the course of pregnancy. Definitely you need to see the woman between the 32 and 34 week period, because that is when you know that there is a peaking of plasma volume. So that is when the circulating volume is at its maximum. So often women can develop signs of pulmonary edema if they have poor ventricular function or some sort of left-sided obstructive lesion. So I think timing of these evaluations is important. Also, remember, as part of the pregnancy, the fetus has to be screened. So remember to refer them for fetal echocardiography. Then, of course, deciding the mode of delivery. Now, it's always difficult with women with heart disease, because there is a tendency for obstetricians to opt for cesarean section because they feel it is more controlled. They feel they have more control over the sequence of events. And it gives them a much better feeling of safety. However, cesarean sections can cause a huge loss of blood and huge hemodynamic shifts. So actually, the safer option of delivery for most women with congenital heart disease is actually normal delivery with a shortened second stage, which means they don't labor on for a long time. So you do everything to shorten that second stage of delivery. You use instrumental delivery, have a low threshold to use forceps to get the baby out. So still normal vaginal delivery is probably the preferred route of delivering these patients, although they do have an increased incidence of cesarean section and instrumental deliveries. And last but not least, there's the risk of recurrence. So the women need to be counseled about the risk of the heart anomaly recurring in their children, and of course you have the structural anomalies and also the inherited abnormalities like Marfan syndrome, which has a 50% chance of being transmitted to the offspring. So all this information should be available to the patient. Of course, just like it is important to deal with pregnancy, in those patients in whom pregnancy is contraindicated, it is important to advise them on how to avoid pregnancy, i.e., what contraception is best suited for them, and how best to avoid getting pregnant. So if you look at the subgroup of patients with cyanotic disease, and these are often untreated patients, under medical management, because most in today's time, most of the patients with cyanotic heart disease would have received either a biventricular repair or gone down the univentricular line and gotten to a stage of a Fontan by the time they're adults and ready to undergo pregnancy. But we still do have a cohort of extremely cyanotic patients who are, often unrepairable for a variety of reasons. And if they do manage to get pregnant, then the fetus carries a very high risk. So of course the mother carries a risk as well, because she has bleeding and clotting problems. Often there is a right to left shunt. So there are bleeding issues with these patients. Because of the right to left shunt, there is a risk of paradoxical embolus. So there's an increase in the intra-abdominal pressure, and there can be paradoxical embolus with neurological events as a consequence. And of course, because a lot of blood is now being shunted to the fetus via the placenta, there is a decrease in the amount of pulmonary blood flow that is available to the lady, and there can be an increase in cyanosis, because placenta is a very low vascular resistance bed, so it tends to suck all the blood out of the woman's circulatory system. So therefore, the pulmonary circulation can end up getting less blood than before, and the woman can get more cyanosed and require hospitalization. Often in this situation, the best thing to do is complete bed rest, and perhaps a bit of oxygen. So it is all completely supportive and supportive medical management. So there is nothing you can do at that point. The fetal risk. Now, a woman who has a saturation of less than 85%, the chances of live birth is only 12%. Okay, so if you have a deeply cyanotic patient, her undergoing pregnancy is not really a worthwhile idea, because chances of yielding a fetus are as low as 10%. Now, if the saturations are greater than 90%, chances of live birth are much better. Okay, so I think a woman's baseline saturation when she comes to you for pre-pregnancy counseling is quite important to predict the outcome of that pregnancy and to give advice accordingly. Next group of patients, again very important, are the pulmonary hypertensive patients. Like I said to you right at the outset, pulmonary hypertension and pregnancy do not go well together. So PA pressure is even 50% systemic, there is a 40 to 50% mortality. The pregnancy is generally contraindicated in these patients, and termination might be an option. Of course, it carries some risk, but less risk than the woman undergoing completing the pregnancy. Contraception issues need to be discussed with these patients, and sterilization might be an option, although yes, it does carry a risk. Any procedure in a pulmonary hypertension patient does carry a risk. So the attempt to predict adverse cardiovascular, neonatal and obstetric outcomes in these patients with cardiac disease, a Canadian group came out with a score which they call the CARPREG score, I think cardiac and pregnancy score, the CARPREG score, and they took into account risk factors including arrhythmias, prior cardiac events like heart failure, TIA, stroke, NYHA class 3-4, cyanosis less than 90%, systemic ventricular obstruction, but if you look at their pressure gradient, it's not that high. And lastly, ventricular dysfunction. So they took these risk factors and devised a score which they then applied to predict the outcome of pregnancy. Subsequently, there was another paper published. This was from Boston, I think, and this paper, in addition to the score, it sort of refines the score in a way. And in addition to these factors, the other two factors that were identified, particularly in repair tetralogy-like patients, was severe pulmonary incompetence in some patients and RV dysfunction as well. So not just systemic ventricular obstruction, but perhaps any ventricular, systemic ventricular dysfunction, but any ventricular dysfunction is a risk factor for pregnancy. So this is a paper, this is quite an important paper on this subject, and I think I would recommend that you guys try and get it and read it. So there are certain patients in whom you would opt for an elective cesarean section, and these patients include Marfan's patients with dilated ascending aortas, who are at a high risk of aortic rupture, and pregnancy puts an enormous strain on this aorta. Similarly, patients like post-coarctation repair patients, or even native coarctation patients, particularly if they have an aneurysm. So again, the aneurysm has a risk of rupture. So aortic problems are an indication for elective cesarean section. If the woman decompensates acutely in her third trimester, then she might need a section. Also, you might have to do the section early, not wait till term. You have to balance the risk of prematurity to the baby versus the risk to life of the mom. And at the end of the day, we look after mom. So our primary responsibility is to ensure that mom has a good outcome. And the baby, although important, is secondary. And it may be that the baby has now reached 32 weeks. The woman is decompensating, and at 32 weeks, the premature neonate will have a reasonable outcome. So at that point, you might have to make a call and deliver the baby so as to help the mom to survive. Again, anticoagulation is a big issue, and there are patients with the Shiley valve and mitral position who are desperately in need of warfarin anticoagulation. So these patients cannot be taken off warfarin without jeopardizing their valves. So in these patients, section gives you better control of bleeding, because you can look at bleeders, you can ligate them, whereas natural, normal vaginal delivery, you've got hairs on the inside, you can't do anything about it from the outside. So this is another sort of unique indication for cesarean section in these patients. Again, severe coarctation, aortic stenosis are indications for elective section, severe ventricular dysfunction. So these are the broad indications for when you would recommend a cesarean section in a woman with congenital heart disease. Now, what I will attempt to do is go through sort of individual lesions quickly, just highlighting certain key points. Now, cardiomyopathy obviously need not be congenital. In fact, in a woman of childbearing age, it's perhaps more acquired than congenital. And nearly 10% maternal mortality is noted in patients with DCM if they are in NYHA class B4. Okay, so the outcome, pregnancy outcome in DCM depends very much on what their EF, ejection fraction, is, what their function is, what NYHA class they are. So the baseline, functional status of the patient determines in a way the outcomes, maternal outcomes. I suppose it's logical, but say if I had somebody who was an NYHA class 3-4. With an EF of, I don't know, 20%, I would advise them against pregnancy. So I think you have to, DCM itself is not a very good disease to get pregnant with. If you've got only mild dysfunction, mild to moderate dysfunction, maybe you'll be okay. But if you've got severe dysfunction, well, you're asking for trouble by getting pregnant. Also, remember that ACE inhibitors cause renal agenesis in fetus, so it has to be avoided. Okay. Hypertrophic cardiomyopathy, there is no added risk. So patients with hypertrophic cardiomyopathy can get pregnant. Now the issue here is not one of adverse outcomes, but it's one of recurrence. So they have a high risk of transmitting the problem to their offspring. So that is something that they have to consider. So there's a 50% risk. Now we talked about peripartum cardiomyopathy. This is a very sort of unusual illness. It usually occurs in the last month of pregnancy up to 5 months post-delivery. Okay, so if a woman who's pregnant develops cardiomyopathy the last month to 5 months post-delivery, that is called peripartum cardiomyopathy. It is not a very good disease to have. It's a high mortality, 20% mortality, and women are left with persistent dysfunction as a result of this. So they have a risk of getting it again if they get pregnant again. So all these issues have to be considered. Sorry. And then, of course, in our part of the world, rheumatic valve disease is important, and as you know, obstructive lesions are less well tolerated than regurgitant lesions. Especially severe MS and AS needs to be dealt with, I think, pre-conception. Moderate lesions might actually worsen a little bit and then be controlled with medical therapy. But occasionally, women have needed intervention even during pregnancy because they have deteriorated and decompensated, and it is too early to deliver the baby. I suppose if the woman decompensates in the last trimester and the baby can be delivered, with minimal risk, then that would be an option. But if they decompensate earlier on and the baby cannot be salvaged, the options are either to terminate the baby or to do some sort of intervention which would be high risk in these patients. Again, the subgroup of patients that are a nightmare to deal with during pregnancy are the ones with prosthetic valves. Anticoagulation is a huge issue. Pregnancy is a prothrombotic stage, and the women are at risk of clotting their valves off if they are not anticoagulated appropriately, and this would have a tremendously adverse outcome. Now, this risk has to be balanced with the risk of embryopathy that is associated with warfarin. So warfarin is associated with embryopathy in the fetus, but there is a dose relationship to this. So if you are maintaining your patient on low dose warfarin, which is defined as less than 5 milligrams, then the risk of embryopathy is very small indeed. So one could argue that these patients who are on low dose warfarin just continue on their warfarin with no increased risk to their fetus. Okay. After 36 weeks, they have to be converted over to heparin so that there is better control of bleeding during delivery. But these issues have to be discussed with the mother. Now, the mother might not want any fetal risk, and then you are left with option of either giving low molecular weight heparin and aspirin during the entire pregnancy, or you can give low molecular weight heparin, aspirin, or IV heparin during this. Oops, sorry, I didn't mean to do that. So the options are warfarin throughout. We went through that. Okay, heparin and aspirin in the first trimester, followed by warfarin. The first trimester is when the embryogenesis happens. So you cover the lady with heparin and aspirin during the first trimester, then you swap back to warfarin during the rest of pregnancy until you reach 36 weeks when you go back to heparin. So this is option 2, or you can give heparin throughout. Now, low molecular weight heparin in some studies has been reported to be more thrombogenic. Okay, so not as effective as using IV heparin. But imagine you having to use IV heparin on somebody who's pregnant throughout pregnancy. I mean, it is just impracticable, right? So, but low molecular weight heparin does put the valve at a slightly increased risk. So you have to weigh the risks and benefits of the various strategies before, and make a joint decision with the family as to what they would like to do. But these are quite complex decisions, and it is not easy to manage a woman with prosthetic valves during pregnancy. Then, as we already discussed, left-sided lesions, for example, say bicuspid aortic valve with mild AS is not a contraindication for pregnancy. If they have moderate severe AS, again, they probably can go through pregnancy without much problem. Now, there are some pressure gradients that are given as cutoff. So, a mean gradient of greater than 50, a peak gradient of greater than 80, this would be a contraindication and probably needs to be addressed prior to the woman getting pregnant. Also, as pre-pregnancy workup, it is important to do an echocardiogram, an ECG, and if possible, an exercise test to look at what the behavior of the ventricle is when put under stress. And if all of that is normal, you can probably give the woman the go-ahead to get pregnant. Of course, she needs close monitoring. But if the AS is only moderate to severe, she'll probably get away with it. If there is decompensation, of course, bed rest is a good thing for pregnant women. So, of course, not complete immobilization and to the extent that they get deep vein thrombosis, but generally, women with congenital heart disease, significant congenital heart disease, pregnant, bed rest is a good thing. So medical treatment can be carried out, they decompensate, and occasionally they need a VAV or early delivery. Again, coarctation, it's unusual to find native coarctation at that age, but it can still happen. If there is severe native coarctation, you control the hypertension and you plan for an elective cesarean section because delivery can increase your blood pressures tremendously. Then repaired coarctation, importance is to rule out an aneurysm. If there is aneurysm, you have to go for an elective cesarean section. Again, malforms with dilated aorta, we've already gone through it. If they have bad family history, if their aortic root is greater than 4 centimeters and there is rapid dilatation of the aorta, pregnancy is contraindicated. And again, in these patients, elective cesarean is recommended. Now, sort of minor lesions like VSDs and ASDs, generally safe. These are low-risk patients. These are the small risks associated, but remember that the magnitude of these risks is small, okay? Not enough to tell the woman not to get pregnant. Then you go on to the group of operated congenital heart disease. I'll just start a few important ones. Repaired cough, generally these women tolerate pregnancy well. So moderate to severe PI, not usually a problem. So the important factors are RV function and arrhythmia, okay? So if your RV function is impaired, then that's not a good thing. If you have significant RVOT obstruction, again, that may be a problem during pregnancy. There is, in terms of adverse events, if you looked at a group of repaired step patients who are pregnant, adverse events during pregnancy, predominantly arrhythmia, both supraventricular and ventricular, can be new onset or worsening arrhythmia, and they can get worsening failure. But overall, as a group, they do reasonably well, okay? But if they have, say, severe PI and if they have moderate to severe RV dysfunction, perhaps pregnancy would not be tolerated very well. So you have to individualize your counseling. But overall, as a group, they can get pregnant. CCGA, like I said before, early pregnancy is better tolerated as the RV is a systemic ventricle, and pacing may be needed in heart block. So CTGA, always remember heart block. Okay, so remember to get an ECG. Make sure that the woman, is not in heart block, because during pregnancy there is a need to increase your heart rate, and if you are in heart block, you could get into trouble. And then you have the subgroup of patients with atrial switch. Here again, the systemic ventricle is the right ventricle. They are at risk of arrhythmias. Pulmonary venous baffle obstruction is very important. So in adults, getting good views of the pulmonary venous and systemic venous baffles can be quite difficult. So do not hesitate to do a TE if required. Okay, so if your transthoracic views are not good enough and you're not 100% certain about the pulmonary venous baffle, then do a TE just to clarify, because during pregnancy, there is an increased circulating volume. These patients will go into pulmonary edema if they have any pulmonary venous obstruction. Okay, and this can be dealt with pre-pregnancy if detected pre-pregnancy. So again, here, worsening of NYHA and function, worsening of arrhythmia, these are the main issues. And a significant proportion of them do have worsening of functional status. Fontan patients, again, they can get pregnant, again, dependent on whether they have good ventricular function and whether they are predisposed to arrhythmias. These patients, however, have high fetal loss, so that has to be counseled. So it's a very psychologically trying time for the family. I think the woman should be aware of the fact that yes, she might try and get pregnant, she might struggle to get pregnant, and she might lose babies on the way. These patients are often on warfarin. Of course, the warfarin treatment is not as critical as in a valve, but warfarin is an issue that needs to be considered in these patients. So in practice, what do? We we've talked about a huge variety of patients that we can come across in our adult congenital clinic with whom we may have to discuss pregnancy. So we can broadly classify them into low risk, moderate risk, and high risk. Okay, under low risk, you would have things like small or repaired ASDs, VSDs. This is not pulmonary hypertension. So just small to moderate lesions, they've been restrictive VSDs all through their life, etc. They just need some infective pericarditis at times. Repair TAPCs, mild outflow tract obstructions, mild regurgitant lesions, all of these are pretty low risk. Moderate risk would be things like repaired TOF, moderate outflow tract obstructions, and moderate to severe resultant lesions, contents, CTJs with good function and no other adverse risk factors. High risk would be pulmonary hypertensive, Marfan's aortic root dilatation, aortic aneurysm, poor ventricular function in any of these repaired categories, moderate to severe ventricular dysfunction, and severe outflow tract obstruction. So this is sort of a practical way of dividing up your patients so that you can counsel them appropriately. So, I mean, I'm just looking at some data on heart block and pacing during pregnancy. So, pacing is not contraindication to pregnancy. So, a woman can be paced and get pregnant without any problems. There are some patients who present with varying degrees of heart block. So, I mean, they're not necessarily complete heart block. This could be sort of second degree heart block, and they found that there is a worsening of the heart block during pregnancy. And the hypothesis is that this is because of atrial stretch. But often this returns to baseline. So if you have a woman who has some worsening in heart block during pregnancy, it's not immediately an indication to pace her because she may come back to baseline. Okay, this study or this data is not in patients with necessarily in patients with structural heart disease. So it's a sort of a mixed bag of lesions. It's only a small number of patients. But still, it gives us some idea because this area there is very limited data. So, pacemaker as such is not a contraindication to pregnancy. And finally, we come to recurrence rates. So you know that the incidence of congenital heart disease in general population is about 8% or whatever, less than 1%. And you know that if there is a family history of congenital heart disease, that just goes up 2 to 3 fold. So it's about 2 to 3%. And again, if the mother carries the problem, there is a slightly higher risk of transmitting it down to the fetus. But it is not that different from if the father carries it. So mother and father, very important. Now, the recurrence rate does vary depending on the lesion. So it can be lesion specific. So I think that is something to be aware of. So when you're counseling a person, say for example, a mother who's had an AVSD repair, and you're talking about recurrence in her fetus, her risk of recurrence is not 3%, it is much higher. So if you look at the data on AVSD, some papers have reported up to 15% recurrence. So I think you have to, and again, lesions like hypercardic left heart, they can recur a lot more. So I think what you need to do is individualize your counseling and not just give a blanket 2 to 3%, but also be aware that there are certain lesions in which there is a higher rate of recurrence, which needs to be counseled. Of course, if you find AVSD in a fetus, you know that you have to screen for Down syndrome. Not if there's a family history necessarily, but if a de novo AVSD, you have to look for genetic problems. It can be difficult to predict the exact lesion in future offspring. So the problem is that a mother comes to you with, say, a simple VSD repair. Now, you cannot tell her, and wants to get pregnant. You can't be certain that, her baby, if it gets a heart disease, will get the same heart disease. It might get a more complex heart disease. Similarly, a woman with more complex heart problems might have a baby with just a VSD. So that lesion concordance is not that high. It's only 35 to 40%. So in 60% of the cases, they are not the same lesion. And in 50% of cases, they are not even the same type of lesion. Okay? Of the conditions that we come across, isometric heart, AVSD, hypoplastic left heart, these have high concordance. So often, if you have the primary person, the affected individual has a certain lesion, has one of these lesions, then the chances that the sibling or the offspring will have the same lesion are high. So they have high concordance. Remember autosomal dominant conditions like Marfan's and HM. I mean, these are they may not be obvious on a fetal scan, but throughout the life of that child, this is going to be a huge deal, and they're going to live with this risk hanging over their head. So it's an important issue to discuss with the parents. Of course, apart from pregnancy, avoiding pregnancy is very important. I'm not really going to touch upon it in great detail. There's a good article which has been co-authored by all these authors in the International Journal of Cardiology I'm sure there are other good review articles available, but the general dictum is that you don't give them the combined pill, okay, because it's got estrogen. Estrogen is not good with congenital heart disease. It can cause fluid retention. It's prothrombotic. It aggravates hypertension. So combined pill is off the list. You can give a progesterone only pill, but it's not as good a contraceptive as the combined pill. So that is to remember. IUDs are a risk for infective endocarditis, so probably to be avoided. You can use the barrier method, but it's not safe all the time, and compliance is a problem. So is it really that reliable? Slightly risky strategy. Okay. Then you're left with things like implantable or injectable progesterone. These are pretty good. I mean, they offer very good contraception. They require less, compliance, because they get done only either the depot injections, I think, get done once a month, and the implantable ones last for up to 5 years. So, one of these options would be a good option. But of course, if the woman suddenly wants to get pregnant in the middle, she has an implantable contraceptive, she has to wait for that effect to wear off before she gets pregnant. But often you would go for these options, the long-term option, after deciding that pregnancy is perhaps too high risk in this woman. But these are some of the options that are available for contraception, particularly in patients in whom pregnancy is contraindicated. So I think with that, I sort of come to the end of this talk. Yes, okay. So I hope this has been useful. I have tried to be as comprehensive as possible. So if you have any questions, anything that you want to discuss, any points of view, please, fire away.